you know, when the families come in and they're aggressive with hospitalizations and aggressive with their treatment, I tell them, you know, and mom doesn't get up and all she wants to do is sleep, and she'll take a bath and go back to bed, and I want her up and I want her doing things. And I always say, why don't you stop and think back when you were 7 years old? Because all of us, hopefully, in this room can think back when we were 7. And think about what you woke up in the morning and started planning your day around. You know, am I going to play with my friends? Am I going to eat breakfast? What's mama or whoever cooking me for breakfast? And compare that to what you wake up and think about now, you know, 15, 20 years later. Some of y'all, it may only be a few years later. You don't think of the same things. You are not in the same cycle as you were 20 years ago. Well, some of these people, you know, a lot of my previous residents were 100 years old. So 40 years ago, to them, they were already 60. You're not going to wake up, even the 100-year-olds are still not going to wake up and be in the same cycle and plan their day and think of the same things as they did when they reached older age. So you have to remember the state of mind and the cycle they are in life, and that will help you to put yourself in their shoes, which is going to make you help them make a better decision about their care. You have to remember their comprehension level. A lot of older adults were raised in an era when they didn't have a lot of technology. They didn't, you know, we go in using these acronyms and these abbreviations and, you know, buzz, blah, 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 and we talk kind of fast and we're, you know, using a lot of verbiage that they don't get. Bring it down a level. Why do we do that? I hate it when people do that to me. If I'm talking to someone like at a bank, which I'm not a financial person, you know, and they're using their acronyms and their verbiage and they totally lose me. I sit there and I think, this is how those poor patients feel. You know, how many times have y'all had someone go in, they explain a procedure to them, blah, 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 they go out, you go in. Can you tell me what they just said? If you haven't experienced that, believe me, you will. And that's all it is. It's just bringing it down a level. You know, this is what they're talking about. We need to check your sugar. We need blood to check your sugar, and it's a finger prick. You don't have to go into glucometer and Accuchecks and use all these words because they are not familiar with that. So you have to remember comprehension level and motivation, which also goes with comprehension level. If they are not motivated to learn this, you need to approach it differently. You may incorporate a caregiver. You may incorporate a provider service. You may incorporate some specific ideas that you've learned just by talking with these people, what their learning style is. You have to remember they may not be motivated to learn or even care to learn. And so you have to be creative to accomplish the goal of safety and to try to keep them as stable with their blood sugars as possible. We just went over the cycle of life and where they are. Please remember these are their goals. They are not our goals. They're not the doctor's goals. We do develop goals because we have to have a standardized way of identifying what we're going to do to help these people. But if we have a goal of, you know, their blood sugar is going to be between 100 and 120, you know, every single time they check it and we do our little thing, we do our check off and we're so proud our paperwork is done, but maybe they feel better at a blood sugar of 85. Maybe they don't care what their blood sugar is. Maybe it gets up to 400 3 times a week. So you have to incorporate and remember these are individuals, whether they have come to a point in life where they can function independently or not. They are still individuals, and unless they are deemed mentally incompetent by a judge, they still make their own decision, period. There's no ifs, ands, or buts. It's their body and it's battery if we touch their body and do anything to them without their permission. Just because someone can't talk does not mean that we don't have to get their permission. There's body language. Now, we may have to use another person sometimes to obtain permission, but we have to get permission before we do anything to anybody. We have to consider others around them, because a lot of times you are working with a population that does need some kind of help, mentally, physically, or both. So sometimes you are incorporating family, and you have to, I start off on the front end and explain to families, especially children, children of older adults, are very hard sometimes to make them understand, yes, this is your parent, but it is my patient. You're not my patient, your parent is. So we have to work together to make sure that we're doing what this person would want us to do. Since you know them the best, I want to use you as a resource to help me come up with the best plan of care. And you approach it from the very beginning so that they know they are not making an all-inclusive decision and leaving out everything that's in the paperwork that maybe mama did 20 years ago, talking about a living will or advanced directives. You have to incorporate the patient or the resident into your treatment plan, whether it's through just them or through somebody else. Then you also have to consider the others that are not around them. A lot of these people need a lot of help, but family lives, you know, up in Washington, down in Florida. So you have, you know, this elderly person that is at home or in the hospital or in a nursing home or assisted living, and they don't have anyone around them, and so they are dependent on maybe a church, on friends, on other entities to support them, but are not going to be a stakeholder in their care like it would be if it was a family. So you have to consider everyone around them and then everyone that's not around them when you're trying to think of how to develop your plan of care. To be or not to be, at home or not at home, this is the question. You have these elderly people that, you know, we all look like, in the stage of life, little toddlers to them. I'm going to include myself in that. They are facing others making decisions for them, especially if they've had a stroke or they have a disease process where they can't communicate effectively anymore. That is very frustrating for them. You will see them lose their temper. You'll see them start to cry. And then we diagnose them with a further level of dementia. You have to stop and remember, and sometimes do it yourself. Just stop in a grocery store, going through the line, and don't communicate with someone. I mean, the first thing you feel this, rush of embarrassment. This is the same thing these people are going through that have had strokes that have affected either their throat, their mind, both. They can't speak and communicate anymore, but they still may want to make their own decisions. And so you have to incorporate, again, the resident, the patient, the person you're working with into the decision, and you have to get very creative sometimes how you do that. Most of these people still feel like this is my life and this is my home. And they don't want people coming in and telling them that they're going to change everything. Well, we're selling the house and you're going here, and then, a tornado hits them, and the next thing they know, they, become aware again, and their suitcase is sitting in the corner, they're in a room, and there's no family around. And then all of us start running in there, doing assessments, and we got to check them, it's like that for like 4 days. Then all of a sudden they realize, I'm not at my home. And it may take them that many days before their mind processes everything that happened and they become aware again of their surroundings. And so really take time with elderly people. Time is so important. I look at people, especially 80 and older, if they have lived that long, I don't care how mean, I don't care how grouchy, they get automatic respect. And the staff that I have worked with, that's what I told them. I don't care how they interact. They try to kick you, you step back until their leg stops. But under no circumstances are we to lose our temper with the patient. They are going to lose their temper with us. It's rare to find an little elderly person that has total control over their emotions and temper at all times. So even if it's that little patient and you just love them, they still may lose their temper and get very frustrated. from nothing more than just the aging process. Remember rights of patients, especially in geriatrics, like I said before. If your patient can't communicate, if you have someone that's maybe been bedridden for years, they have severe contractures, they're still alive. They are still alive and they can still experience some quality of life. We have to intervene and we have to find what that quality of life is for them. Even if it's one special something every day. I used to tell the staff at Golden Manor, you know, walk in these doors and the only thing I ask is that y'all put a smile on your face. Because sometimes these little old people, that's all they want to see, is a younger person smiling. And they've told me this hundreds of times. That's all that would just make their day. Go ahead.
They also like to be touched too.
Right.
Yeah.
They do like to be touched, but I do want to warn you about so much touching. You know, look in this room, 50, 60 people in here. There's some people that aren't the, you know, touchy-feely types of people, and that will invade your space. If you're just that kind of person that doesn't go up and hug everybody that you see, and you have a distance around your body that's your space, so do these people. And so I always ask them, can I give you a hug? Can I just give you a kiss this morning? Or sometimes if they get used to you, they'll ask you, can I give you a kiss this morning? Sure, give me a kiss. So you have to be careful. The touching and the stimulation other than verbal, you just need to get either body language approval or they'll tell you if they can communicate. But she is right. Let me tell y'all really quick. There was a girl that came to Golden Manor that had those little tiny chihuahuas, the little teacup chihuahuas, and I got one, and then the activities director got one. And I'm not joking, they looked like little wind-up toys that you put, and we would bring them to work, put them in the middle of the floor, and they would just play, and they looked like these little tiny toys. The first day, of course, everyone was in there, and we had to pass them all around, let them hold them, and they would rock them, and we put the clothes on. By the time I left Golden Manor, which the little dogs were only 2 weeks old at that time, so we had brought them every day for 2 weeks, they had started the coffee group at 10:30 every morning just to go play with their babies. And so, and now the activities director still brings hers every single day. I've been a little bit bad. I haven't gone back and brought Chip. That's my chocolate Chip. It's my one. And he's only he's 1.5 pounds now. And he's like almost 6 months old. But you have to get creative. There were so many people that we had, you know, labeled as depressed, and they were staying in their room all day, and you'd ask them, well, I like watching TV. Well, I like to read all day. As soon as we got those little dogs in there, they were out of their room almost all day, and were the main ones that kind of fought to hold them. They'd get first in line with their wheelchairs. It was like a little race to get down to the activity room because they got to hold the dogs first. And so, you know, that sparked some interest. It gave them not only an hour or two of socialization together, but it also, I'm sure, brought back a lot of memories. They'd be sitting there holding this tiny little infanty fetus thing. It didn't even look like a dog. It was so little. But, you know, they had their little blanket, and they'd just rock in their wheelchairs. And the ones that had a lot of symptoms from stroke, we'd, you know, prop their arms up, and we did the whole pillows. And, I mean, they were just, oh, and they were just so excited. It was so worth it. So remember little things like that. It doesn't necessarily have to be something alive. Personally, you know, when I get there, please give me something alive. But some people react that way to just a very soft, plush, stuffed animal. My mom and dad both died of Alzheimer's. And my mother was really odd. Had a ceramic dog. It was like a beagle that we used to have when I was little. And she treated this like hard, cold ceramic dog like, you know, you see a little kid that holds a little plush animal. And she would just pet it, and it was right there, and you took it away, and she was looking and kind of worried about, you know, who had it over there. And so you never know what it's going to be. You know, when you see that spark, that's when you get an opportunity to give someone a moment of quality of life. Decisions, decisions, decisions. How many times do y'all get at the end of your day and you're like, my brain hurts, I can't think anymore, I can't decide. Even you go through a drive-through and you're like, you know, and they're like, do you want curly or spicy or regular, large and small? And you're like, and I did this, I did it last night. Will you just decide whatever's the best one and give me that one? I'm not picky with my food, so whatever you give me will be fine. It always kind of stuns someone. They're like, you know, okay. Or either like you go out to eat and, you know, here's the specials, and then I'm like, whatever you would order tonight, that's what I want. Surprise me. You know, you really take people off guard, but that is how tired sometimes you feel like you get. I can't make one more decision, not even a yes, no. Think about, go forward 50 years from now. We've made that many decisions. Can you imagine how tired we're going to be? How tired our brains are going to feel to make any decision at all? So keep that in mind when you go up and we have a lot of, you know, questions, and we have our paperwork and our regulation check-off list and all this. Really, they don't care about all of that. And we're getting all detailed about skin and the history, and most of them can barely remember the current past history. You know, 30 years ago, they could have had cancer, but already forgotten about it. It was a whole life ago for them. And so when we're asking them, please remember, we're talking about 30 to 40 years of history. And so if you get a current, you know, within the last couple of years, you're doing pretty good. We have to remember resources. Who's there to help them? What, you know, do they have steps to climb? Have they had a stroke? Are the doors wide enough for wheelchair? Basic things that you cannot develop a plan of care unless you consider and incorporate. And we have to remember, we have to facilitate and help the physicians with the ordering, because a lot of times they just want to, you know, take care of them, kind of send you on your way. So these are the things, and use your resources, use social work, use the ancillary staff to help you with your plan of care. Everyone has to come together and work as a team, because not any one healthcare profession can effectively cover all the bases that really need to be covered with a patient. We have to, in this day and age, and this next one, financial concerns, is, you know, soapbox of mine. I hate that we have to consider that with healthcare. We're talking about humans here, not machines. Unfortunately, we live, you know, past the year 2000, so we have to remember and try to be aware of all the different insurance regulations, Medicare regulations, Medicaid regulations, third-party payer, all these, you know, words that you hear buzzing around. But I will tell you, and I've been involved with almost every type of insurance and Medicare plan, and now they've got massive amounts of Medicaid plans. The basic on all of them, if you get rid of all the regulations up here, you go down to the bottom line is, do we provide good inclusive care? Did you look at everything? Did you assess everything? And did you write it down? If you do that, 9 times out of 10, you're going to cover whatever regulations are out there. And it does get down to being very basic and very primary with your care. Remember what you learn. You know, you go through body systems, you chart it. If you do something, you chart it. And that's what they will validate their payment on. It's a big, let's see, what's the word I want to use? Onus on these little old people when things are denied, because they don't come back to us that didn't chart it. They get a letter. Most of them don't have eyesight anymore to even read the letter. And all they know is they didn't pay for something. And they put in there the reason was because the service wasn't covered. So we have to remember, we are making their lives harder, whatever setting you're in, when we do not document what we do, when we don't document and justify that there is a need for a nurse or a physical therapist or a social worker. We have to just tell them why they're there and what we did. You document it simply and short as you can, and you will never get denied. 9 times out of 10 you won't get denied if you document everything that you assessed and that you did. We also have to remember the ability and the capability of the geriatric population. You know, I've talked a little bit mentally and physically about their ability. Also we have to remember their ability to be able to function at home may not be an option. It also may not be an option for them to go into a facility. So here you are in the middle. You have someone over here that may or may not have family to help them make decisions, that's absolutely not going to go into a facility of any kind. But on your side, they absolutely cannot stay home because they can't feed themselves. They can't clean themselves. At that point, social work needs to get in immediately. You can call Adult Protective Services. They go in and they perform evaluations, and they have experts to go in and intervene without using force generally to help these people take care of themselves. So we have to remember their ability and capability when we're helping them to make these decisions. And then choosing the right home health agency. There are a lot of services out there. There are a lot of different types of agencies out there that do a lot of different types of services. So when you're considering a placement issue or identifying an agency to go out and perform home health services, you might want to encourage them to shop around a little. There's always girling. But you want to encourage them to look around. It's not just something we look around when we go and we look for services or we're buying something. So we need to afford them the same opportunity. Most of the time, 90% of the time, you're going to be in the middle of a dilemma with geriatrics and family and or caregivers. And then the other part of the time you're going to be in a dilemma between the physician goals and the patient goals. And so a lot of times the healthcare professionals are the ones that get stuck in the middle of this, web of decision making. I always tell people just to stop and step back, identify what the patient wants, and effectively communicate that. There are so many ways to make people understand. Say you have a physician that's the one way and that's the only way I do it and that's the way it's going to be. Encourage them to get a second opinion. They may need to talk with a different physician. Physician-patient relationship is very important. And they need to get along, and they need to know that the physician and the patient are going to listen to each other. There's got to be a bond of trust. Same thing with caregivers. You have to tell them if they don't get along and feel trusting of their caregiver, they need to shop around until they find someone that they are trusting of. And not just because, well, that's the only one that was available, that's the only one that would come. Yeah, we do get stuck in that situation sometimes, but if you are resourceful and you incorporate some of these ancillary services, you will find a way to find someone that can come and be regular, be responsible, and come and take care of them in an effective manner. The main thing we need to remember when we're talking about any kind of placement issues or whether someone's going to stay at home or go in a facility is if they're safe. If we can identify they are safe, there is a way to figure out how to help them stay at home. I went over briefly about the roles of healthcare professionals. We all need to be involved with care. The teamwork cliches you've heard the last 10 years, they really do mean something when you work as a team, when you communicate, when nursing communicates with social work and therapy are communicating, when the physician and therapy are communicating. That is when you have a very successful episode or patient care treatment plan, and that's where we need to head. Please don't forget rights of your patients, even if they are demented, even if they are old, even if they're over 100. Whatever the circumstances is, they have rights. We've got to remember them. Some other guidelines when we are developing some treatment plans are, remember, if it's reasonable and feasible, if you have someone with multi-organ symptoms of failure and they get a new diagnosis of diabetes. That, you know, what does that mean? My heart's been sick for 25 years. My liver, you know, numbers have been high for 10 because I take so much medicine. And now you're telling me my sugar's what? I mean, really, what does that mean? You know, for us, if that's the only disease we have, it means one thing. But for someone that has 7, 8, 10, 20 sometimes diagnoses, it does not mean the same thing as if you have a healthy body and you have one diagnosis. So we have to remember when you're developing your treatment plans, and you're trying to decide, excuse me, if this person can stay home or needs to go in a facility, we have to remember, is it reasonable and feasible? Sometimes it's time just to make them comfortable. Sometimes it's, you know, there's not going to be a lot of active options out there, and we want to manage symptoms and keep them comfortable. You want to remember to individualize your goal setting. It's got to be something that the patient's going to be able to do or reach. This is very applicable with the therapies, but it's also applicable with all healthcare professionals. Don't set goals way out there. It's frustrating for you because then you have to do massive documentation that means nothing because they're not going to ever reach those goals. Do small steps and small goals. Both of you get to reach them and then set another one. You can set as many goals as you want. You keep progressing. When you find out that you've stopped progressing with a goal, that's when you step back and you have to look, what are the options now? We may need to change the treatment plan. Then you implement your plan that matches the patient. After you have looked at them, you've discussed this, you've seen financial, looked at caregivers and families. Then you implement a simple plan that matches that patient. Diabetes in particular takes a lot of time. These people sometimes can't see to read the tiny window on some of these new glucometer machines. So we run in there and we teach them how to stick their finger and you put it on, it beeps, and 10 seconds later you have your reading done and we run out. And then they're sitting there looking at something about this size and they're kind of going like this, and they're still learning how to use the remote. They're still learning how to use push on the phone. And so we have to remember that just checking your blood sugar, which seems like such an easy, quick thing to us, can be very cumbersome and frustrating for them. So if they're not able to do it, there are ways we can get blood sugars checked through home care, through healthcare professionals, through going to the clinic at scheduled times. There's a lot of ways you can help them get their blood sugars checked. At that point, most of the time I try to get involved the family or have one of the providers that's going in either oversee the process, read it for them, or perform it for them. Everyone is teachable that helps take care of them at home. And so it's a lot of times that's what your option is to go ahead and incorporate someone to do it for them. Diabetic foods, I don't mean this as a pun, but take it with a grain of salt. It is very important to have a diabetic diet. But I will tell you, the sugar taste buds are the last ones to go when you're in the elderly stage of life. The first that you go in, what do you want, ice cream? What do you want, you know, a bowl of broccoli, or do you want chocolate cake? Chocolate cake. So what I incorporated at my previous facility, Fridays were sugar day. They all got ice cream, they all got cake, and we just gave them extra insulin. And I used to tell the physicians, this is the way it's going to be. I had 2 parents. You know, we took care of 15 years, and they ate whatever they wanted. And I think it's unfair for us to look at someone that's 85 years old and say, you can't have chocolate cake. Or you can't have a big, you're giving bowls of ice cream to everybody, and they're sitting over there with their diabetic cookie. I mean, we have to remember, you know, there are limits and there are standardized plans and there are standardized ways to treat the disease process, but we have to, quality of life to me is 110% more important than any standardized plan of care. So please remember, if you have someone that cheats on their diabetic diet, incorporate that into your plan. You can call it non-compliance for regulatory purposes, but that doesn't mean they can't enjoy something every once in a while. We just have to be aware if they have the tendency to have 600 to 800 blood sugars, we have to make sure they know what that means. It may affect your eyesight, may affect your kidneys. You know, as long as you know this and it's documented that you taught them and then they choose for their own body to do it, let them go do it. They have more bad days than normal geriatric patients. So we have to remember the blood sugar and everything around us may affect it. If they get a little virus, it may affect their blood sugars. And so they just feel just the exhausted, tired, a lot more days than the normal population that's in geriatrics, which already feels a lot of bad days and they're creaky and achy. So you add the diabetes and the sugar variation and they definitely have more bad days. We have to remember supplies for management. What can they use? What's the dexterity of their fingers? What's their eyesight? You have to remember to ask for specialty, and occupational therapy can help with this a lot. Ask for specialty devices and supplies. If it hasn't been developed, develop it. You'll be a millionaire this time next year. So I'm always, you know, see these things come out that healthcare people have made and developed. I'm like, this has been a problem for 20 years for me. Why didn't I think of this? And they're all over the sites to order for DME companies. So use your DME companies. Ask them, I need a blood sugar machine that has a font of 72. When you read it, you'd be surprised how many will all of a sudden find one for you. All of them have at that age chronic conditions, so we have to remember that the chronic conditions and the chronic states, we're not going to necessarily reverse, we're not going to necessarily help. We need to be symptomatic treatment planners. We help them be comfortable. We may cure them. I'm not saying it's not curable, but we have to remember we're starting with a disease process that would affect a young, healthy person. So you have an elderly person that already has an aging body and you're adding another disease process, and you have to remember that it's going to be a chronic condition. So you have to tailor your plan to be ongoing and continuous. There's also a false hope of belief of compliance and they're still unstable. If you see someone that has 20 and 600 and they're just sitting there, you know, oh, they're so cute. And they're looking at you saying like, I don't eat any sugar. I never cheat. My blood sugar is just, I don't know why. I don't. Don't sit there and tell, I know you're not doing your diet, you know, and believe me, there are healthcare people out there that treat them this way. Okay, let's review. You know, you help them identify. Let's write down, they can't remember what they had yesterday. Well, let's write down what you ate 30 minutes ago. And they may tell you, well, it was a whole wheat donut. And to them, that's healthy. I wasn't cheating, it's a whole wheat donut. This actually happened to me. And I said, but you know, donuts still have sugar on them. And it's the sugar part, not necessarily the flour part we want to focus on here. And a lot of times they'll be like, oh, but other times it'll be like, and they kind of like ignore you because they already knew, but they thought they could get by with it. So if you find someone like this, help them to find a diet they can stay on. Help them to learn about the different types of sugar substitutes. There are so many out there now. There's yellow sugar, there's blue sugar, there's pink sugar. There's, you know, I mean, help them find something they can work with. Help them find that sweet taste without necessarily making their sugar go up to 600 or 800, which it does. Taking time just for diabetes. No, they are not. Generally speaking, they are taking time for multiple symptoms, multiple previous diagnoses, developmental age, just their age in life takes time. They can't pop out of bed, they'll pop their back out. I'm already at that age. They can't just run, pull the shower on, jump in, do a quick shave, wash the hair, and get out and run, get in their car. Most of them, it takes them 30 minutes to clear their head enough to get up and go in then to check their blood sugar and to take all their medications. So remember that the diabetes takes a lot of time, the age they are takes a lot of time, and other conditions take a lot of time. So sometimes you're working with someone that if you get them out of bed, you get them clean, get them fed and comfortable where they have their crossword puzzles or magazines or TV, whatever is their daily routine, that is their day. That's all they can handle, because then they have to repeat it backwards that night. They have to get back up. They have to check their blood sugar, go to the bathroom, change clothes. All of that is their daily routine. And so we have to remember all the time it takes for just moving sometimes, getting from point A to point B. Also, a lot of these people are just too tired to try. They are so exhausted, and the bed is so comfortable. One of the things that I used to tell them at Golden Manor was, you know, if you have someone that's a late sleeper in, why do we think we have to wake them up at 5:30, 6, 6:30, 7? It's time for your bath. You know, it's kind of cold to them. Even if the water's hot, but you can't be that hot, you're going to burn their skin because it's overly sensitive. You know, let them sleep in. Who cares if they have breakfast in bed? You know, if the family gets upset, you say, you send that family to me, and I'll sit them down and say, how many times do you pop out of bed when you're sick? You know, and you run in there, and you're all, if you're sick, you feel bad, you want to stay in bed and eat breakfast in bed. Nothing wrong with that. Eat lunch in bed. Why is that such a bad thing to us? Let them relax. Let them have this time to enjoy, be pampered. You know, I would tell staff, don't get all upset about it. Let them miss a bath. Ooh, you know, give them a sponge bath. As long as they're clean, their skin is intact, we're doing a good job. Remember the ancillary staff, social workers. Please remember home health. That is where healthcare is going. Acute hospitalization stays are down to about 2 days now. So a lot of people are coming out of hospitals post-op, post-serious procedures, and they are at home, whereas 10 years ago they would have been in the hospital another at least 5 days. And so it's very important, I think, for them, especially nowadays, to have home health following any hospitalization. Always use your support resources. Dietitians are very important in this game. There are some references in the back that we'll get to in just a minute that are approved by Medicare for reimbursement. Also remember your educators. There are educators that just focus on disease processes, diabetes being one of them. These are our local San Antonio education programs that are approved by Medicare. You have to be a Medicare-approved educator to get reimbursed for it. It still has to be driven by a physician order. That part doesn't change with anything. The physician has to order everything that an insurance is going to cover. There is the site and the program name, the address is actually out here on Medical Drive, phone number, and program ID. Use these resources when you are looking for people. They can do one-on-one. They could have groups. Girling, actually, I brought just a couple of examples of our disease management booklets. These are tailored for patient education. One is in Spanish and one is in English. We try to have multiple languages for all of our patient education material. We also try to send out the staff that can speak the language of the patient. Fortunately, in San Antonio, it's basically Spanish and English, and the population statistics are usually about the same as staff statistics. So you can look at the patients as they come and fold into your site, whether it's inpatient, outpatient, or home care, and you can assign the right staff for that patient. I'm not going to be one that's going to be able to go out and fluently speak Spanish to someone. I mean, I'm like, hola, you know, it would be pointless for me to go out and be interacting with someone that speaks only Spanish. You know, it's going to be frustrating for me. It's going to be frustrating for them. If that is the only option, you carry pictures with words under it. You know, you take something that's going to facilitate the communication. This is another local Medicare approved program that is in the San Antonio area. This is one of the local diabetes educators that is a Medicare approved educator. And that's my grandbaby. She is pretty cute, isn't she? That's how she acts all the time too. She's always sticking her tongue out and plugging her ears. That is all I have today. I want to open it up for some questions if anyone's got anything or additional comments. If y'all have been through some different situations that might help the group. Share your situations with others. You wouldn't believe the times people have shared different cases and situations with me, and maybe one small thing they told me will help me with the patient down the road. So y'all talk and share. You know, even if someone makes fun of you a little bit, who cares? Let them make fun of you. You're just giving someone else a break. Y'all been very attentive. I appreciate y'all letting me come here today. I enjoyed it.